Greetings and welcome. My name is Elizabeth Soto Cardona. I am the Center Manager for the Scleroderma Vasculitis and Myositis Center here at Hospital for Special Surgery. Just want to go over a little housekeeping before we get started. Can you hear me? Can you hear me well? Yes? Okay, thank you. Okay, we will mute everyone and ask that you turn your video off to help facilitate a better presentation with less interruptions for technical and bandwidth issues. Questions can be typed in the chat. I will present your questions to the speakers at the conclusion of the presentation. Today's webinar is being recorded and will be available on the HSS-SVM website at a later time. The address will be in the chat shortly. For HIPAA privacy considerations, the question and answer portion of the program will not be recorded or available to the public. We would appreciate if you would complete the short evaluation at the end of the program. This will help the speakers develop future educational programs for you. You will find the link in the chat box and on the PowerPoint. The Scleroderma Vasculitis and Myositis Center at HSS and the Tri-State chapter of the Scleroderma Foundation have a long history of collaboration. Just wanted to share a little background on the Scleroderma Vasculitis and Myositis Center and the Tri-State chapter, for those of you who are not familiar with what we do. With the vision and guidance of Dr. Robert Spiera, we at the SDM Center have created an infrastructure for clinical, translational, and basic research in scleroderma, vasculitis, and myositis, as well as for community outreach and patient and physician education. The Tri-State chapter of the Scleroderma Foundation served the scleroderma community in New York, Connecticut, and Northern New Jersey, with a mission of support, education, and research. For more information on the chapter, visit their website at sclerodermatristate.org. For more information on the HSS SVM Center, I'll share the link with you guys. Today's program will feature Dr. Robert Spiera presenting scleroderma systemic therapy in 2023. Dr. Spiera is the director of the Scleroderma Vasculitis and Myositis Center at Hospital for Special Surgery and a professor of clinical medicine at Weill Cornell Medical College. He has been the principal investigator in several clinical trials and observational studies focusing on scleroderma and vasculitis. Dr. Spiera specializes in the treatment of various rheumatic conditions, including scleroderma, vasculitis, systemic lupus, and Sjogren's syndrome. He has authored over 150 publications relating to scleroderma, vasculitis, and other rheumatic diseases. Today's program will also feature Mary Rose Murray Carey and Baptiste Nicolas presenting research participation, taking action, fostering hope. Mary Rose joined HSS in May 2022 as the social work manager of the rheumatology division. She is responsible for the strategic direction, planning, and operational oversight of the program initiatives related to advancing the highest level of service to the community. She manages all aspects of social work services, including patient care, program planning and evaluation, and the development of procedures and protocols to address social work needs. She ensures the patients who are at high psychosocial risk are assessed and provided with appropriate resources and referrals, and advocates for patients' needs through collaboration with the entire healthcare team. She is responsible for the supervision of social work staff in adult rheumatology and the Voices 60 Plus program. Her professional interests include the development of emerging clinicians, psychosocial issues around terminal and life-limiting illness for patients and their families, and the improvement of healthcare access and disparities. Baptiste Nicolas works with HSS adult rheumatology patients who are coping with a new diagnostic or chronic condition like scleroderma. As a clinical social worker, Baptiste works closely with the medical team to assess any barriers to care and finds workable solutions to enhance the patient's quality of life. He has a real interest in reducing the emotional impact of chronic illness on day-to-day function and improving access to care at HSS. Again, please type your questions in the chat. We will do our best to respond to as many as possible during the hour program. I will be monitoring the chat room and combine live questions. We will start today's program with Dr. Robert Spiera. Welcome.
We really are looking forward to doing these things in person again. All of this stuff doesn't happen. The talk today is going to be Scleroderma systemic therapy in 2023. And there has been an evolution in the way we approach the treatment of scleroderma in the last 2 decades or even in the last 5 years. This may be a talk filled with slides that are maybe way too technical, but I kind of want to at least give some of the background data that helps us inform our decisions or our suggestions when we make recommendations to patients with scleroderma. And these are some of my disclosures, which means there are groups that I work with that are enthusiastic about developing therapies for scleroderma. So when a patient comes to see us from the doctor perspective, they'll ask us, well, how are you going to treat my scleroderma? And much of that, as you know, has to do with guidance regarding appropriate screening for things like whether there's a lung issue or a heart issue, maybe coordinating with other specialists like gastroenterologists to help manage heartburn, or referrals to occupational therapists, or to cardiologists if there's any evidence of something called pulmonary hypertension. But the rheumatologist in general is making most of the systemic therapy decisions. And these relate to things that we're hoping to really modify the disease course. And often those are issues related to lung involvement, skin involvement, or musculoskeletal involvement. So there's systemic therapy, which means, let's say, medications or other interventions that might just be addressing organ-specific complications, such as, blood vessel dilators for Raynaud's phenomena, or certain blood pressure medicines if there's kidney involvement, or hypertension, or supportive things for reflux, or other adjunctive things we'll do for musculoskeletal limitations. But this concept of disease modification is something that lives in our other rheumatic diseases that is starting to become a real thing in the treatment of scleroderma, meaning therapies that address the systemic ongoing processes that lead to the different problems that emerge in different organ systems. And by way of introduction, there are 2 drugs approved for scleroderma, but they're specifically approved for scleroderma-related interstitial lung disease. So they're organ-specific, and I'll talk about that more later. There are multiple drugs approved for pulmonary hypertension. Again, that's organ-specific. It's not for scleroderma in general. And then there are things to think about when we think about what would really disease modification mean in this condition that can have so many different manifestations in so many different people. So for one person, stomach issues might be the main problem, and another, progressive skin changes might be the problem. So it's hard to define for us as clinical researchers agreement on what outcomes we should look at in our trials. And I'm just giving that as a backdrop to how we approach this. I'm skipping that slide, but when we think about, is disease modification possible in terms of addressing that underlying process that drives scleroderma, there have been 3 basic approaches looked at. One are therapies that suppress the immune system. We know scleroderma is an autoimmune disease, so as in some of our other rheumatic diseases like lupus, medications that might suppress that overactive immune system might be helpful. Some therapies have addressed inflammation, which is a big part of the early phases of scleroderma. And then there are some therapies that are very promising, we think, that actually address this process of fibrosis, like the development of scar tissue. But there's no great proven disease-modifying therapies for many different features of the disease, but some seem to be emerging. So there are 2 drugs approved for scleroderma, which was not the case the last time I spoke to this group about this topic. One is called nintedanib, and one is called tocilizumab. And these were both approved for scleroderma-related lung disease. And I want to talk a little bit about them in a little bit of a granular way, just so you understand what goes behind these approvals. Nintedanib, the brand name is OFEV, that I imagine some people in the audience are using, is an oral molecule that targets something called tyrosine kinases. And maybe 12 years ago, I talked to this group about a trial we were doing with a different tyrosine kinase inhibitor called imatinib, which turned out not to be helpful for scleroderma in a safe way, although it helped some people and it wasn't ever fully explored. This is a drug that has similar targets, and it interrupts the activation, proliferation, and migration of fibroblasts, which are the cells that create excess scar tissue, and the conversion of those fibroblasts to something called myofibroblasts, which are very active cells in perpetuating that scarring phenotype of scleroderma. And a very large trial that was reported already 4 years ago at this point, was called the Census trial. It looked at 580 patients. They needed to have lung involvement because it was a trial designed primarily to see whether this drug helped lung involvement in people with scleroderma. They had to have new-ish disease, but not very new disease. So patients could be enrolled in the trial if they had even up to 7 years of disease. They had to have ILD, I want to mention that term, interstitial lung disease, on a CAT scan, a high-resolution chest CAT scan involving at least 10% of their lungs. And they could be on background medications, and they were then randomized to receive this drug nintedanib or to receive placebo. And neither the patient or the doctors knew which they were getting. And then the patients were followed for that year. And the primary outcome of the trial was to see to what extent a measure called the forced vital capacity, which is part of those pulmonary function tests that many of you probably do yearly or twice yearly that assess lung function, how it declined in people getting active drug versus those getting placebo. And what was found is that people getting active nintedanib had less of a decline than people getting placebo. So if you look at the decline in patients getting nintedanib, it was only about 60 milliliters per year, a little bit less than that, 55. Whereas in the group getting placebo, there was more of a decline. So this was exciting. This was a drug being proven to make a difference in the progression of lung problems. It was a complicated design because most of us in this country now would treat patients with scleroderma with lung involvement with this drug mycophenolate, or Cellcept is the brand name. And the trial showed that if you were on nintedanib plus mycophenolate, you had the least decline. If you were on no background therapy and placebo, you had the most decline. And looking at it another way, the group that declined the most was the group that was on no mycophenolate, this dotted line, and got placebo. If you got mycophenolate, but were randomized to placebo, you declined a little bit, but not as badly as the other group. If you were on no mycophenolate, but got nintedanib, you declined less. And the group that did the best were on mycophenolate and nintedanib. So this was sort of exciting, and it talked to some synergy between the mycophenolate and nintedanib. And there were side effects of nintedanib, so a lot of GI side effects. Up to 3/4 of the patients being treated with active drug developed diarrhea, which is a big issue in patients with scleroderma. And there were many, many side effects in that group of patients. These were not necessarily dangerous, but it gave some of us pause in using this drug in certain patients. But it was an exciting trial, and it was the first drug approved in scleroderma. I should mention a couple of caveats, though. We looked at other outcomes in this trial, including whether this drug afforded improvements in skin involvement, meaning less worsening of skin, or let's say improvement in skin, and it did not seem to do that. It was uniquely restricted to a benefit in terms of lung. The next drug, these are both drugs on the market that was approved for scleroderma-related lung disease, was a drug called tocilizumab, or Actemra. And this was also an interesting experience. This was a drug that blocks a very inflammatory molecule called interleukin-6. It's a drug that we've been using in rheumatoid arthritis for over a decade. We've used it in another condition, in one of the conditions that Liz mentioned that I have an interest in, called vasculitis, but there was rationale to think it might help scleroderma. So the trial on which the approval of this drug for scleroderma lung disease was based was not a trial focusing on lung disease. It was a trial looking at whether this drug helped people in scleroderma more broadly than that, which enrolled people with scleroderma, relatively early disease, less than 5 years since their diagnosis. And the primary outcome of the trial, what the trial was hoping to look at, was whether patients would get less worsening in skin or more improvement in skin if they got active drug versus placebo. And as opposed to the other trial I mentioned, this trial did not allow people to get background therapies. So to enroll a patient in your trial, we actually elected not to be a site for this trial because we didn't want to enroll patients with early active scleroderma in a study in which they might be randomized to a year of placebo therapy. We thought there was enough indirect evidence that other things would be helpful, like mycophenolate. But suffice it to say, the trial happened and enrolled about 200 patients. And indeed, it did not show that this drug was effective for skin, which was the primary outcome. But if you look at what it did to lung involvement, the red line looks at people who had the active drug, Actemra, tocilizumab, and the blue line shows people getting placebo. And you can see that there was a deterioration in the lung function in people getting placebo, whereas there was stabilization in the group getting active drug. And actually, the FDA, I think, kindly looked at this data and said, you know, we are in need of better therapies in scleroderma, particularly for lung disease. So this group of 68 patients getting placebo and 68 patients getting tocilizumab, that was a subgroup of patients in the study that happened to have interstitial lung disease. The trial did not require that be present, but it showed that this drug seemed to help that subgroup of patients. So again, this drug was approved. Well, what about other strategies? You know, many of you don't have interstitial lung disease, and really there are many other things that are problematic, of course, in scleroderma other than just lung disease. So there's been a variety of medications that have been looked at in what at this point are well-done trials, including a drug called cyclophosphamide, that drug called mycophenolate, or CellCept that I mentioned. I'll use the abbreviation MMF. There's a drug called methotrexate, which some of you may have seen in the past. There's very aggressive strategies, which I'll try to show a little data about, but where patients get very high dose chemotherapy, and then they get a bone marrow transplant to reconstitute their immune system. And that's been used in 3 well-done trials. And then there's a new approach that we've been very interested in here, using what we call anti-B cell strategies. So as we make decisions about systemic therapy, we really, as doctors, have to think, what is limiting the patient most at this time? Is it their skin? Is it their lung? Is it their musculoskeletal concerns? And even if they are being, let's say, bothered more by their skin than by their lung, what do we think is going to be most dangerous to them if it's not addressed in the ensuing months? And that's something really where the communication between the doctor and the patient is important. We have to hear you, and you have to also, we have to be able to communicate to you what our other concerns are and why they might be important. And that often speaks to issues with the lung or the heart. And then there are other considerations relating to optimizing the patient's choices. So some of our patients may be thinking about pregnancy in the future, which can happen in patients with scleroderma. And there's some drugs we'd want to avoid if that was something that was going to possibly happen, like cyclophosphamide, which is often associated with infertility. So the first study, and this is an old study, this is 2006 that it was published, was a study looking at a drug called cyclophosphamide. It's like a chemotherapy drug, but it can be given orally daily. And it was the first randomized large trial done in scleroderma of close to 160 patients across 13 centers. And patients got this drug orally for a full year. or placebo for a full year. And the primary outcome was to see whether it afforded improvement in lung. So you had to have lung involvement to get into this study. And the bottom line is it did show that this drug, cyclophosphamide, in that first year resulted in less decline than did treatment with placebo. So there was about a 1 point difference from baseline to 1 year in that measure of lung using active drug, and about a 2.6 decline if you use placebo. So that's a small difference at a very high price in terms of how substantial that drug is, but at least it showed that immunosuppressive therapy can help. The problem is the follow-up to that study, when we looked at patients at 24 months, at 2 years, that benefit was no longer present. So if you look at the line of patients getting cyclophosphamide, it was favorable compared to placebo at 1 year. But then after another full year, when patients might or might not have been on cyclophosphamide or other therapies, they came back right back to the same baseline as people on placebo. So that really dampened enthusiasm for that strategy. So the toxicity of that drug, along with its durability of response and only modest benefit, really led us to question cyclophosphamide. And although that was a positive study, and we still use it in some very sick patients who have very bad lung disease, we usually use it in a very restricted way and very infrequently. So this other drug, mycophenolate mofetil, and I'll go through some of these slides quickly, is a drug that ended up replacing cyclophosphamide in the treatment of lupus kidney involvement. In lupus, kidney disease was treated with cyclophosphamide for years and was a very effective therapy, but it was recognized almost 3 decades ago that this much safer drug, mycophenolate, worked as well. And there was evidence that it worked in skin. And then there was some open label data suggesting that patients getting this drug fared better than patients getting no therapies or other therapies with scleroderma. And I'm going to go through some of that quickly, but this was a drug that compared mycophenolate to cyclophosphamide. So we knew from 2006 that cyclophosphamide was better than placebo. This was a trial that wanted to compare mycophenolate to cyclophosphamide for patients with scleroderma and lung involvement. So they compared 2 years of cyclophosphamide to 1 year of, 2 years of mycophenolate to 1 year of cyclophosphamide, and then looked at a similar group really to the group that was looked at in the census trial, in the nintedanib trial, and looked at their primary outcome was the lung outcome. And in fact, it showed that in this study, interestingly, both patient groups, the cyclophosphamide group in the solid line and the mycophenolate group, both actually got a little better in the first year of the study, and that benefited persisted even at 2 years out. But the benefit was comparable between groups, and you were much more likely to still be on mycophenolate because there were far fewer side effects, which is what we would have expected. And especially in young women hoping to preserve their fertility future, or young men, mycophenolate is a much safer drug. The trial did not primarily look at skin, but obviously many patients had skin involvement. And this is a complicated slide, but I'm just going to summarize the top line result. If you compare this group of patients in terms of how their skin fared compared to the group of patients on placebo in SLS1, mycophenolate seemed to show a benefit with regard to skin as well. This is another indirect study that supported the idea that mycophenolate, CellCept, is helpful for skin. So many of you heard me talk about the linabicin trial. It was an oral cannabinoid. It was the largest prospective trial done in scleroderma, where we allowed patients to be on whatever background therapy their doctors wanted them to be on, and they got either linabicin or placebo. And the bottom line is we did not demonstrate treatment with linabicin to be better than placebo. But what this allowed us to do, it was a very large study, it was 365 patients. docs in different countries use different drugs. Different people have different practice patterns. This is a super complicated slide, but I just want to take you through one piece of it. Let's look at the change in the skin score. And this is patients, the gray bar, who just got no background therapy, meaning their doc said, well, we don't think anything works. We're not going to give them anything. They had a little bit of improvement in skin, not quite what we would think is as important. They got about 4.5 points better in skin over the course of a year. But if you look at the group that got mycophenolate, MMF, they got on average 8.6 points better, which we do think is important. Whereas if you look at the group getting methotrexate, they were pretty similar to the group getting no background therapy. Perhaps more impressively, if you look at the change in lung outcomes, the group getting no background therapy got much worse. The group getting mycophenolate stayed pretty stable, and the group getting methotrexate did get worse. So this was an opportunity for us to explore, and this was presented at a national meeting, and we're developing the manuscript. The suggestion here was that mycophenolate is a good background therapy for people to be on. And I think that we're seeing more and more mycophenolate use, and I think we're going to see that continue to increase over time in people with diffuse scleroderma. So it's increasingly being looked at as a disease-modifying medication in patients with diffuse disease, and in some cases in patients who have not even necessarily widespread skin disease, but whose presentation would make you think that they're going to progress in that direction based on certain antibodies or other clinical features. There's evidence of it helping skin and lung. There seems to be good safety and tolerability in patients with scleroderma. And I think we're seeing it more and more as a standard background therapy in interventional clinical trials. I will say for people with what's limited scleroderma, what used to be called as CREST, we don't really know that there's evidence for it being helpful unless there's interstitial lung disease. But there is a trial in the UK that's looking at that. So at this point, I would say I'm going to talk for a minute about methotrexate. I do have patients on scleroderma. On methotrexate who have scleroderma. It seems to help a lot with joint inflammation or muscle inflammation. Janet Pope, who you've all heard from in the past, published a nice study suggesting that there were benefits with regard to skin. But generally, we avoid it in patients who have lung issues with scleroderma because it can irritate the lung. And I think we're finding that mycophenolate is emerging as a favored therapy as opposed to methotrexate. When talking about approach to systemic therapy in 2023, I do think we should talk about autologous stem cell transplantation. There have been 3 well-done studies looking at this. One was a small study of about 20 patients from Northwestern. One was a larger study from Europe. It was about 156 patients. And one was the Scott trial here in the US. And in all of these trials, the active treatment group was treated with this very aggressive immunosuppression regimen where you're basically having your immune system largely wiped out, and then it's reconstituted with your own bone marrow. That would be the active treatment group, and the comparator was intravenous cyclophosphamide, that drug I spoke about earlier, the chemo drug, once a month. And all 3 suggested a benefit to transplant over cyclophosphamide. This is just data from one of the slides, just showing that the overall survival over time in the transplant group was better than the cyclophosphamide group. And what we call event-free survival, years without a major event like renal failure or pulmonary failure, was better if you got transplanted than in the cyclophosphamide arm. So there's definitely some proof of concept there. But there were complications of that immunosuppressive approach, not surprisingly. So for example, Scott, in the trial here in the US, patients did better than in the European trial. But in the European trial, there was a 10% mortality in the first year in patients who underwent transplant. So there's a lot of hesitation about widespread application of high-dose immunosuppressive therapy and transplant, but there are some patients in whom that might be appropriate. There are some concerns about secondary cancers. There have been concerns about, okay, I go through that very aggressive regimen in the hospital for several weeks at least with it. I have some risk of succumbing in the first year to that intensity of therapy. But if that means a life free of disease, maybe it's worth it. The long-term durability is being demonstrated, but there are some patients that I've taken care of and others have who have relapsed after some period of time. So that's some of our hesitation in not always recommending that approach. Well, what other strategies are out there? And I'm not talking about very investigational things. I'm talking about things that are maybe almost ready for prime time. One are what we call anti-B cell strategies. Your immune system is made up of many, many different kinds of cells, but some of the major classes of cells include T cells, which is part of what we call cellular immunity, and then something called B cells, which have gotten a lot of attention during the pandemic, because those are the cells that develop into something called plasma cells, which make antibodies. So when you get a vaccine response, for example, you want to have reactive B cells so you can develop a good antibody response so you're protected from whatever the vaccine is targeting. But we know that there are many lines of evidence, which we've known about now for nearly 2 decades, that B cells are important in many rheumatic diseases, including rheumatoid arthritis. So anti-B cell strategies have been approved there. Vasculitis, anti-B cell strategies have been approved there. In lupus, there's a drug called belimumab, which targets B cell pathways, which was approved. And there was rationale to show that it might help in scleroderma, where we know that these activated B cells interface with something called dendritic cells, which are cells that sort of sit here in that interplay between those T cells and the fibroblasts, which make those proteins that lead to that scarring response. So about 2 years ago at this point, not even, a trial of a drug called Rituxan was published from Japan, which was initiated by the investigators. It was only done in Japan, and it was placebo-controlled. And it was an interesting design. This doesn't transmit well, but basically what they did is they took patients, and they did not have to be very early, and they did not all have diffuse scleroderma, but they randomized them to receive either Rituxan, an infusion every other week for 2 infusions, or placebo. They did not allow background therapy. And what they were able to show at 6 months was that if you received placebo, meaning you had scleroderma but got no therapy, as in some of those other experiences I showed you, your skin score got a little bit worse, or at best didn't get better. Whereas if you got active Rituxan, you got about 5 points better, and overall that was about a 6-point difference from placebo. So that suggests Rituxan was doing something in skin. Moreover, if you looked at that lung outcome measure, the forced vital capacity, if you got placebo, you got worse. That's the blue line. Whereas if you got Rituxan, you stayed exactly stable, which is what you want. You don't want your lungs getting worse. So again, it was an encouraging signal. There are caveats there because they did not allow background therapy, which again, I could argue with the ethics of that trial design. It was a small study. It was only about 52, 54 patients. But it was enough that Rituxan was granted regulatory approval in Japan by what they call the PDMA. That's the equivalent of our FDA. So in Japan, Rituxan is an approved therapy for scleroderma at this point. Our group, I mentioned an interest in in B cells and scleroderma, we initiated a trial of belimumab, a different anti-B cell strategy, back about 8 years ago. And this study was published about 5 years ago, where we randomized 20 patients to receive either belimumab or placebo, but true to our sense that patients should be on background therapy, all of these patients with early progressive disease received mycophenolate. And both groups improved overall, but it seemed that you were more likely to be a responder if you got belimumab. So that's the blue group here. Were more likely to be belimumab. You were less likely to be a non-responder if you were in belimumab. And you were more likely to be a non-responder if you were on placebo, and less likely to be a responder if you were on placebo. And overall, the skin scores got better in each group on average, but there was a trend towards suggesting that belimumab might be helpful. And this was what we call a translational piece of this study, where we did biopsies in people before and after therapy. And we showed that those who improved on this anti-B cell strategy actually were the same people. When we looked at gene expression, we were able to show that they were the ones who showed downregulation of those B cell mediated pathways. So it said that this wasn't just a coincidence. You only got better if you were somebody where the drug was actually having a biologic effect that we can measure, not just the clinical effect, but the expected biological effect. So right now, actually, our center is doing another investigator-initiated trial where we're combining rituximab and belimumab, which is a strategy that's been used in other bad rheumatic diseases like lupus kidney disease, in a single center study. This is ongoing and we're enrolling, where patients are treated with either, everybody gets background mycophenolate, CellCept, and then half of them get Rituxan for 2 infusions, like in the Japanese trial, and then belimumab for a year, whereas the other group gets placebo infusions, then placebo. And at the end of a year, in the blinded part of the trial, everyone has access to belimumab. And again, we have some confidence that this might add something. And interestingly, in the last half year, the company GSK that makes belimumab has invested in a very large, what's called registration trial, looking at whether belimumab is superior to placebo in a very large multi-center international study, looking at belimumab compared to placebo, allowing background mycophenolate, very similar to the design of our initial trial. So this is just our ongoing trial. So basically, summarizing what I said, for limited scleroderma, I don't generally favor systemic therapy unless there's lung involvement. For diffuse scleroderma, often we use mycophenolate. If the patient is refractory, we think about Rituxan. We think about methotrexate in some patients, especially if they have very active inflammatory arthritis or muscle inflammation. Very selectively, we refer people for bone marrow transplant. And we very much consider interventional clinical trials, but our group tends to prefer trials that allow patients to have background ongoing therapy so that patients aren't being randomized to nothing. If interstitial lung disease is present, we often use mycophenolate, and in some patients, we either add an nintedanib or tocilizumab, or in patients without diffuse scleroderma who only have lung involvement with limited disease, we'll sometimes just use nintedanib or tocilizumab. And these last 2 slides, I could have Elizabeth share later. There are a number of trials that we're actively doing here in the center or are about to start here in the center. But in the interest of time, I won't go through these now. Okay, thank you guys very much. Okay.
Thank you, Dr. Spiera. Thank you so much for that.
Okay.
Informative.
You can get me, okay. Thank you.
So Dr. Spiera, I wanted to, there's a couple of questions, but I wanted to say that to after Mary Rose and Baptiste's presentation. Can you stick around for a little bit?
Absolutely.
Thank you, thank you, thank you. Okay, thank you everyone for joining. And now for the second half of our uh, presentations, I will lead you. Please welcome Mary Rose and Baptiste. I'll lead you with Mary Rose and Baptiste.
Welcome, and thank you again, everyone, for joining us today. We are very happy to be here. My name is Baptiste Nicolas, Hospital for Special Surgery's Adult Rheumatology Social Worker, and this is Mary Rose Carey, Social Work Manager of Rheumatology HSS. We would also like to thank Elizabeth Soto Cardona from the HSS SVM Center for inviting us to present, as well as Dr. Spiera for the excellent information he shared. Today, we are going to talk a little bit more about participating in research and how we as social workers can help you in that process.
We'll be taking just a few minutes to go over our learning objectives today. These include talking about and understanding some of the common concerns around research participation, sharing some of the potential benefits of research participation, and also sharing resources available for support at all times, as well as support for you specifically if and when you decide to take part in any studies.
So while we're here, mostly to talk about the benefits of participating in research, we know that there are reasons why people may not want to do so. Some of these more common concerns include the inability to distinguish the care from the trial from your clinical care. You know you've enrolled in a trial, but it really doesn't seem much different from what you were doing before. So you may think, what's the point in this extra work? You may be worried about being in a lottery situation. Clinical trials are usually randomized, so you may not be sure which treatment you are getting, real or placebo. Trial enrollment comes with a lot of reading and paperwork and a lot of fine print. This may cause confusion due to medical jargon or language barriers. You might be worried about loss of privacy and fear that your medical information is now available for access. You might have a lack of trust in the medical system, which can be particularly true for people of color, women, or older people, or be afraid that you are just a test subject for an unproven treatment. And finally, you might feel a little disengaged because you may not know the outcome of the study.
All of these concerns that Baptiste just discussed are both very common and very normal. Research participation might be a brand new concept for you, and it's natural to have some hesitance. You can always discuss these concerns with your doctor, the research team, and any support staff involved, including social workers. However, even with these concerns, there are some very well-studied upsides to participating in research as well. These potential benefits include helping others. Your willingness to take part in research may lead to breakthroughs that bring health benefits to many people. Increased knowledge. You may gain additional knowledge about your own condition and about innovative ways to manage it. You might combat feelings of helplessness. You're able to be proactive. Having a chronic illness with limited interventions can sometimes cause feelings of helplessness, while participating in research allows you to take more control. You'll have access to the newest treatments, as well as multiple medical professionals who are involved with the research study. You'll be very closely monitored. Any changes, for better or worse, will be watched and discussed with your treating and research team, and necessary interventions can be taken quickly. And finally, it's very possible that you can see real improvement in your condition or well-being. Wanted to share one specific resource dedicated to providing additional information on clinical research participation. The Center for Information and Study on Clinical Research Participation, Inc. is a nonprofit organization dedicated to offering resources and programs to help you stay informed about clinical studies. It can tell you ways to best approach your doctor if you're interested in studies, as well as good questions to ask while you make decisions.
There are many places to get further information about individual experiences with research, as well as to hear about research being done and potential opportunities for participation. A great place to start is in the support groups for your particular condition. It's a chance to connect with other members, ask questions, and hear about different people's experience with research. And the social workers who work with your physician are also a great resource for information, support, and helping you communicate with your healthcare team. The programs listed here are at HSS, but you can always check with your physician's office on support services they have available.
Thank you so much for joining us today, and we hope that this was informative for you. Our goal is always to make sure anything we share is useful, and you can help us ensure that by completing this short survey. We appreciate your participation. Thank you.
Thank you.